discussing another bucket, if you will, which are causes of chronic diarrhea, malabsorption conditions. So the big take home with malabsorption type chronic diarrhea is the stool itself. It's bulky, greasy, malodorous. So when you start hearing those terms describing the stool, that's when you want to start thinking, okay, for chronic diarrhea, this is probably some type of malabsorptive condition. And we're going to talk a lot of these in further detail in other lectures, but they're listed there for you. We'll get down, we'll talk vitamins, we'll talk celiac disease, liver disease, tropical sprue, giardia, and then short bowel syndrome, and don't forget about small intestinal bacterial overgrowth, SIBO. You'll see it listed there. But once again, the big thing about malabsorptive conditions, chronic diarrhea, key in on is the stool itself, bulky, greasy, malodorous, and usually accompanied by some weight loss. Pancreatic insufficiency also a cause of malabsorptive type chronic diarrhea. So moving into the last couple of different classes for our chronic diarrhea, then we move into chronic infections. Like I mentioned yesterday, probably got more than your fair share of these from Dr. Graham. Infectious disease, but parasitic infections like giardia and intestinal nematodes. And then finally, systemic conditions. Thyroid and diabetes both can lead to chronic diarrhea. Usually hyperthyroid, but in not all cases, but hyperthyroid can cause chronic diarrhea, whereas hypo can cause constipation. But you can have varying symptoms with thyroid disease. And like I said, diabetes can lead to chronic diarrhea as well. All right, so the clinical findings for chronic diarrhea, the things we want to ask our patients, which is kind of the same questions we ask, whether it be acute, whether it be chronic, whether it be nausea and vomiting, but we want to know specifically for diarrhea, is it continuous or is it intermittent? Does it happen all the time or it come and go in waves? Is it related to meals? It's a big one, right? Does it occur at night? Do you have diarrhea that wakes you up at night? Does it occur if you're fasting? Remember we talked about osmotic. If you fast with the osmotic, it's going to get better, right? Your diarrhea. Ask about appearance of the stool. As I mentioned, bulky, greasy, malodorous. Start thinking malabsorption. Is there blood or pus? Obviously, we need to be looking at some inflammatory diarrhea categories. Medications, always for GI disorders, nausea, vomiting, diarrhea, constipation. You want to ask about medications and look at ones that can cause those symptoms. Weight loss, a big one. If they got weight loss, start thinking alarm symptoms, right? And then for chronic diarrhea, psychosocial stressors, because it can be irritable bowel. Very different than inflammatory bowel. People mix them up because you see IBS or IBD. One's an inflammatory disease, one is a syndrome, right? Inflammatory bowel. Irritable bowel syndrome. All right, so our alarm features, not much different than we've been discussing alarm features for anything in the GI tract. Whereas dyspepsia, new onset, over 60, we got to go straight to the EGD. For chronic diarrhea or constipation, we're talking age of onset after 50. So just a minor distinction there, but an important one. Alarm features would also include, like I said, nocturnal symptoms. If you're being awoken at night because of your diarrhea. Rectal bleeding or melena. What's melena? The dark tarry stools, right? So there's usually some in there. There's some blood in there. Unexplained weight loss. Progressive pain, distinct systemic symptoms, or systemic symptoms. Laboratory abnormalities. If you've got chronic diarrhea and you get back your CBC and you've got iron deficiency anemia, we're going to start thinking some type of GI bleeding, right? You're losing blood in the GI tract. elevated C-reactive protein or fecal calprotectin. I think we mentioned yesterday that calprotectin, non-specific inflammatory or GI lab finding. It's a protein, it's linked to neutrophils, but you just need to know it's a non-specific inflammatory marker. And if your patient has chronic diarrhea with a family history of IBD, inflammatory bowel disorder, Crohn's, ulcerative colitis, that is genetic inherited disorders, so you want to kind of key in making sure you're ruling out any kind of inflammatory bowel disease with your family history, or any history of colorectal cancer in the family. Those folks, with those alarm features, just like for dyspepsia or upper GI issues, get an EGD, alarm system symptoms here, and alarm features, they get looking the other way, right? Or from bottom up, colonoscopy, looking at the colon. The workup, labs, as we discussed with nausea, vomiting, and or acute diarrhea, kind of the same ones, right? Blood count, metabolic, thyroid, because we mentioned thyroid can cause diarrhea or constipation. ESR, CRP, so more signs of inflammation. A celiac panel, we're going to talk about celiac sprue in later lectures, but you can look at the inflammatory markers specific for celiac to see if they have celiac disease. Actually, the antigens or antibodies. And then there's stool studies that we talked about yesterday, right? Culture it, see what it grows. The lab cultures it, see what it grows when you send it in. Leukocytes, the calprotectin or lactoferrin. I just mentioned calprotectin. We talked about lactoferrin briefly yesterday. Same thing. It's non-specific sign of inflammation in the GI tract. But they're looking at it in the stool in this case. Occult blood, obviously we can do our DRE and do our little finger swipe and test it right in the office, or we can send off the stool sample and have it checked. O&P, that's those parasites, whether it's the parasites themselves or their ova or eggs. Electrolytes, and then qualitative fecal fat to see if there's a fat malabsorption problem. If you have the alarm system symptoms, start thinking about the colonoscopy. And that's going to rule out inflammatory bowel disease, or those patients with some anemia, older age, family history of colorectal cancer. That colonoscopy, they can also take samples if they find abnormal growths and rule in or rule out a neoplasm, so colorectal cancer. Other studies, 24-hour stool collection. What that does is much like a 24-hour urine. In this case, you collect all the stool for 24 hours, and then when you send it to the lab, they give you a total weight and a total fat. And that's to rule in or rule out some malabsorptive conditions that we'll discuss here in just a bit. So treatment, depending on what category it is, that's how we choose to treat it. Treat the underlying cause, right? Loperamide, kind of your first line. When do we not give loperamide? Anything inflammatory, right? If you've got something inflammatory, whether it's infection or you've got inflammatory autoimmune process going on, we want to watch out with loperamide because we can let, things can start to fester if we're blocking up the bowel. Codeine, rare to use, but it is still used. Clonidine, we specifically use that sometimes to treat secretory or diabetes-induced chronic diarrhea. Octreotide, those are for your carcinoid tumors. So if there's a carcinoid tumor-induced diarrhea, then we use octreotide. And then also, if you have bile salt induced, then we can use some bile salt binders. And those last two or three, obviously, we're talking specialty management, not so much us as primary care. Most of chronic diarrhea involves a specialist, right? Just like we talked about with vomiting, yesterday when you start getting up into those third and fourth lines. We want you to a specialist involved with chronic diarrhea. If your first and second line things, lifestyle changes aren't working, you don't really see any causes that you can treat from one of those 7 categories that we put our chronic diarrhea into, get a specialist involved. And pretty much most things after loperamide on this list, you're going to be in consult with a GI referral. Okay, and for the visual learners, this nice chart of everything we talked about yesterday and just finished up, how you can manage it. These 2 charts in this lecture, both from current medical diagnosis and treatment, are a good foundation, right? With the memory jogs, looking back here and kind of following your algorithms. And all it is an algorithm of all the things I discussed on the earlier slides. Memory jogs are there for you to review. Like I said, I think you're studying to these. And then last night I posted either 4 or 5 check on learning questions on your card under GI1 block, GI1 lecture 1. And then today, this evening at some point, I'll add ones for this lecture, which was intro GI2, and now we're moving into GI bleed. I'll post those as well. So pretty much after each lecture that we conclude, I'll post those 3, 4, 5 check on learning questions with the answers and then the justification for right and wrong. Just kind of like we did for block 1 and 4, right? Okay, so that will complete our chronic diarrhea, and we're going to move on into GI bleeds. Like I said, the memory jogs are there for every lecture already if you download them. So let me change out slide decks here. And we will get right into GI bleeds. All right. So GI bleeding. We won't get into the task, but you can read them in your lecture on the card if you'd like. Basically, we're going to look at upper and then lower, and then obscure and occult. Define those and figure out the workup and treatment. So GI bleeds, we're going to hit kind of the broad category, and then future lectures when we start breaking down, like if we get to it today, esophagus, and then stomach, and then small intestine, large intestine. So we'll hit it more specific once we talk about that region in the GI tract, but we'll hit it as a broad overview today with alarm systems and acute treatments and diagnosis. So ligament of treats. It's an important landmark in all of GI bleeding. It's the transition between the duodenum and the jejunum in the small intestine. So basically it divides bleeding into 2 categories. Above that ligament, or proximal to it, is an upper GI bleed. Below it is distal to the ligament. So lower GI bleed is always distal or below ligament of treats, and upper or proximal. So very important anatomical landmark. So usually any kind of question you get, whether it boards or any kind of GI question with GI bleeds, we're going to start thinking, is this above or below the ligament of treats, which leads us to now how do we approach an upper GI versus a lower GI bleed. So as I said, upper GI, that's above the ligament of treats. So normal symptoms, so hydemysis, what is that? Vomiting blood, right? Melena, we just talked about it. So that dark tarry stools. And occasionally you can have hematochezia if the bleeding is massive, which is what? Passing blood was stool from the rectum. So vomiting blood, and then the melena, usually with an upper GI bleed, as it moves through the GI system, then it's going to be dark and tarry because it's coming from the upper GI tract and then proceeding through the rest of the GI tract. But if you have a massive upper GI bleed, you can have frank blood or hematochezia from an upper GI bleed. But usually that's much more volume of blood loss from the upper GI tract. With lower volumes, it's going to be that melena because of the changes that happen to the heme as it moves through the GI system. We want to worry with an acute upper GI bleed. Look for those signs of hypovolemia, tachycardia, hypotension. Those are alarm symptoms that we need to probably address this now versus later. Most common cause of upper GI bleed, PUD, peptic ulcer, like 40%. Other causes, portal hypertension, esophageal varices, which we'll get more into in the esophagus lecture, but basically dilation of those veins in the esophagus can lead to an upper GI bleed. Mallory-Weiss tear, that's when we have that mucosal tear of the esophagus, a lot of times associated with retching, vomiting and retching, high pressures, usually associated with alcoholism. Angiotexis, with bleeding out of the arteries. Esophagitis, so inflammation or erosions in the esophagus can lead to an upper GI bleed. And then we always, with a bleed, want to rule out malignancy, right? Any type of tumor. And then we'll talk more about the Borhath syndrome, which is complete rupture of the esophagus. We'll get into that lecture. And anytime you have variceal bleeding, like that esophageal varices, or a Mallory-Weiss tear, or that Borhath syndrome, then high mortality rates. So how did the patient come in? How do they present? Bright red blood, right? Or a coffee ground material. So hematosis, hematemesis of bright red blood or coffee grounds. So that's the blood that's broken up. So what they're vomiting out could be frank blood, or it could be coffee ground appearance with the blood in the vomit. Melena, we defined it, upper GI bleed. A lot of times with those lower volumes, it's going to be black tarry stool. Can occur with as little as 50 milliliters of blood loss. So melena is a pretty good sign of having an upper GI bleed. And then, as I mentioned before, massive bleeding, you may get that hematochezia. So you may be passing per rectum, bright red bleeding with massive amounts of blood loss in the upper GI tract. And then always pay attention not only to what you or the patient is seeing as far as blood goes, but are they having any pain? Where's the pain located? As we mentioned in the early lecture yesterday, like what quadrant are we talking? Lead us towards specific areas to focus on as far as what organ or what may be going on in the system. So what's the first step in any bleeding patient? Stability, right? Hemodynamic stability. We probably need to stop the bleed if they're bleeding massive amounts. Is the patient stable or are they unstable? Right, so we assess it, stable, unstable, stabilize them immediately. Don't wait on your special studies. Don't be waiting on an EGD for an upper GI bleed if the patient is hemodynamically unstable. We have to stabilize them. So usually fluid or blood, depending on how much blood loss they have. And then, are we going to admit them or are we going to discharge them? Most upper GI bleeds, we're not sending home. We're doing something about it there. Some cases, yes, we may monitor closely, start them on some type of treatment as long as they're stable. If they're unstable, they're getting admitted. And then once we stabilize them, then what do we need to do to definitively treat, right? Because stabilization is just. Okay, so how can we approach that, right? So those studies, EGD. So we'll probably go to an EGD, and if we need to cauterize or band, or as he mentioned, some type of surgery, we can do that with endoscopy, right? So we'll move on to an endoscopy, and treat it, whatever the condition is appropriately, and then we can talk about some pharmacotherapy. So unstable, stabilize them, and then start thinking about those follow-on studies, endoscopy, and then needing surgery or not needing surgery based on what you find on your scope. So concerning findings for stability, right? If you start getting the systolic blood pressure below 100, be scared. You need to be doing something for your patient to stabilize them. Heart rate over 100, start moving towards that unstable side of things. And then normal pulse and normal BP. Okay, maybe we can slow down here and treat this outpatient and do some studies, not immediately or admit them. But think, ER related, emergency medicine related here. GI bleed, stable, unstable. And then use those key metrics to determine if the patient has significant blood loss and is moving into shock territory. So if they're unstable, what are we going to do? Well, we're going to treat them emergency, right? Get 2 large bore IVs in, grab some labs, because these patients are probably going to end up being admitted, but we want to get a complete blood count. CMP, PT, INR, right? We want to know how they're clotting, what their clotting factors are doing, and then in case they start having more bleeding and they're already unstable, we probably want to type and cross-match to know what kind of blood product we might be having to give to our patient. So give them the IV, grab some labs, then get some fluids on board, some isotonic fluids, so that you don't have any shifting of the fluids out of the intravascular system. If they need red blood cells, there'll be some criteria, whatever you're working, to say, okay, let's get some packed red blood cells in. And then NG tube used to be used a lot more often for upper GI bleeds, kind of fallen out of favor a little bit. Less common now because we can use endoscope, right? So, but NG tube can help with aspiration of blood or coffee ground material, but just getting the airway cleaned up. But now we have the endoscopes and NG tubes, not used as much, but still in some places. And the endoscope is going to give us a little bit better information too, right? We can actually diagnose with the scope, see what's going on. So there's a lot of scoring metrics out there. We won't go into those. You'll get those in emergency medicine. So I'll leave it to those folks to talk about the scoring systems for assessing the risk for rebleeding and or mortality. But your high-risk patients, unstable, they're getting admitted to the ICU. And even your low to moderate risk are probably going to get admitted for a GI. So here is your take-homes for your high risk of having a repeat upper GI bleed or increased mortality, right? All the things you would think of. Older patients, so over 60, a lot of comorbidities. We talked about the blood pressure. If their systolic blood pressure is below 100, then they're higher risk of rebleeding and of mortality. Or if that pulse is up into the prompting patient level, right, above 100. Or if you get the bright red blood, nasogastric aspirate or pulmorectal examination. So if you get bright red blood when you go down with the scope, or you're sucking out with the NG tube and you're getting bright red blood, or when you go in with the scope you're seeing bright red blood, that's going to increase those mortality rates or higher risk of rebleeding. In other words, if they're actively bleeding when you're examining them, signs aren't so great. And they're going into the ICU. So follow-on care. After they're released or they move to the step down, acute upper active GI bleed is going to get an EGD. Normally within 24 hours or 12 hours if they're unstable. You're going to stabilize them, and then you're going to get an EGD and see what's going on. We can diagnose with the EGD, and then we can stop the bleeding with an EGD. And then we can also give a prognosis for rebleeding with that EGD. So those are the reasons that we're using it so much more than the nasal gastro tube. And know the numbers, board numbers, and also what roles the endoscopists play in the upper GI bleeding. But know the numbers of the hours. Right? Any upper GI bleed within 24, unstable is getting an EGD within 12. Usually it happens a lot faster than that, but that is your board numbers. And the slide at the bottom talks about when we say you can get therapeutic action from the endoscope. Well, what can we do with the scope when we're in there looking? We identify it, and then there's your options, right? Cauterize it. We can give some type of injection that will vasoconstrict the source of the bleed, or we can put something in there like a band or a clip to close it down, suture it shut, right? And then we use it to the EGD to as a prognostic tool, assess the risk of rebleeding. 2 medications common in upper GI bleeding, PPI, right? Anything upper GI, we talk about PPI. In other words, GERD, dyspepsia, H. pylori, but also in GI bleeds, commonly we're going to use a PPI to reduce the acid, right? So whatever's injured in that upper GI tract, we want to keep the acid off of it to not worsen the inflammation that's going on from the bleeding source. And the PPIs, by reducing the acid, will help promote clotting wherever the bleeding is coming from. And triotide, that reduces your portal pressure. So for your variceal bleeding, we're going to talk about the triotide more when we talk about esophagus, varices, or Mallory Weiss tears, or, heaven forbid, a Borges syndrome. And that's an IV medicine that reduces the portal blood pressure. So that's going to lower your risk of rebleeding because you're lowering that pressure of from the portal hypertension. Now we go into lower. So it's below what ligament? Ligament of tricuspid, right? Most of the time, these bleeds are going to be in the colon. Compared to the upper GI bleed, these patients have lower mortality rates. What does that mean? The upper GI bleeds are more dangerous, more deadly. Usually not serious blood loss from lower GI bleeds that you may have with an upper GI bleed. Here's your exhaustive list, right? Anorectal disease, hemorrhoids, fissures, ulcers. We're going to differentiate all those in a further lecture when we start talking about anorectal disease. But lower GI bleeding, hemorrhoids and fissures and ulcers kind of present in certain ways, and we'll talk about those. Diverticulosis, remember painless, bright red blood in large volume. Painless, bright red blood, rerected, large volume. Diverticulosis. It will be on your boards. Inflammatory bowel, big cause of lower GI bleeds. Inflammatory bowel disease, 2 kind of flavors, ulcerative colitis and Crohn's disease, and we'll break those down. We'll have an entire hour on inflammatory bowel disease and the difference. A lot of it is just where it's taking place in the bowel. Infectious colitis, so an infection of the colon, yes, you can get acute lower GI bleeding. We talked about any blood, we want to worry about neoplasm. Same for lower as upper. If you're bleeding, we want to rule out that there's a malignant cause. The angioectasis, older patients, that's just frailty of the blood vessels in the GI tract. So that as you age, those vessels get frail, they can rupture and cause lower GI bleeds. And then ischemic colitis. Age is going to often help us narrow the differential on our lower GI bleeds. So the presentation of lower GI bleed, yep, they're passing blood. With or without pain. Now we'll talk about the clues to let us know which one of those etiologies we need to focus more in on. Just remember your acute lower GI patient, GI bleed. What do they present with? Blood or rectal. Hematochezia, either with or without pain. So age matters. Less than 50, lower GI bleed. Start thinking anal rectal disease or IBD, especially if there's a family history of IBD or an infection of the colon. If you're over 50, then we start thinking about diverticulosis, which I just told you, the hallmark kind of those large volume, painless blood. Malignancy, over 50, worry about cancer. Angioectasis, that's what I mentioned. You start getting the vessels get frail as you age, and then you start having spontaneous bleeding from those GI vessels under pressure in the GI tract. And malignancy. Color is important. Lower GI bleeds, right? And hematochezia, is it bright red? Usually it's left colonic. Hemorrhoids, fissures, diverticulitis, IBD, colitis. Maroon, usually small intestine or right colonic source. And then black, tarry, melanin, right, upper GI. So basically, depending on where you're bleeding, it's going to go from darker to more red, right? So if it's up here as it passes through the GI tract, it's going to start coming out black, tarry, with melanin. As you move down the GI tract, when it's coming from small intestine or the right side of the colon, so earlier on in digestion, then it's going to be more maroon. And then we start getting down into the rectum, and we start getting into distal colon. That's when you're going to see bright red bleeding, because why? It's not traveling through the GI tract. It's not undergoing any kind of changes, right? It's coming from directly near where you're seeing the blood when they pass per rectum. Pain versus painless matters. So painful, anal fissures and external hemorrhoids or lower GI bleed. Like I said, we'll discuss each of those in further lecture. If you have abdominal pain and cramps, then start thinking some kind of inflammatory issue, right, with the lower GI bleed. Is this IBD or is it colitis? So an inflammation or an infection of the colon. If it's painless, could be internal hemorrhoids causing painless lower GI bleeds, or it could be diverticular bleeding. And we talked about diverticulosis briefly and how that presents. Pain was going to, as I mentioned, be an anal fissure and external hemorrhoids. And then volume matters. Large volume, painless, diverticulosis, diverticular bleeding. Small volume with pain, cramping, IBD, inflammatory bowel disease. Hemorrhoids are going to be small drips into the toilet or blood on the TP when you're wiping. And people will freak out, oh, there was blood everywhere in the toilet. Blood expands quickly when it hits water, and so they think it's a massive amount of blood, but it's only a few drops from hemorrhoid bleed. Bloody streaks on the stool, small amounts on the TP, or small drips in the toilet. So think pain, no pain, color of blood, and then how much blood. You can have significant blood loss from the lower GI bleed, but not as common as the upper. As I mentioned, mortality rates are lower. As with the upper, are they stable, not stable? Actively bleeding, we need to do something to stop that, right? So look at hemodynamic stability, which are the same way we looked at for upper GI bleed, looking at it from an emergency medicine lens, right? If they're not stable, do something about it before you start doing all kinds of special testing. And here's the evaluation for our acute lower GI bleeds. Kind of same as with anything in the GI tract. We want to see that CPC, CMP. Look at iron in your upper and lower GI bleeds. Why? Because if you have the hallmarks of iron deficiency anemia, we're going to think that you got some type of bleed going on in the GI system. So it could be chronic if you're starting to see anemia in the patient. Microcytic anemia, rule out chronic bleed. Continue with test. Exclude upper GI first, and then we can start talking about the studies that go from the bottom up, right? Here's your list, and I'll briefly talk about one versus the other, but for diagnostic testing, first rule out upper GI, and then we can move into looking into the colon and the large intestine with either colonoscopy, endoscopy, sigmoidoscopy, you can do nuclear bleeding scans, angiography, or capsule endoscopy. Next slide, I think I talked a little bit about each one of those. So yeah, anoscope, what are we looking there? Quick, in the office, take a look, small tube, and you're looking at just the anus and rectum, looking for hemorrhoids, fissures, anal warts, any rectal tumors. Usually painless, usually not done with any anesthesia. You can go back to whatever you were doing after you leave the doctor's office or after you leave your office with an anoscope, in most cases. The sigmoidoscopy, so that's just looking at the lower third of the colon, so the sigmoid and the rectum. It's less invasive than a colonoscopy, faster, easier prep. Any of you have ever done a bowel prep for a colonoscopy, you pretty much have to get everything out. So go lightly or some type of osmotic laxative to clear your entire system out before you go in, and they can see your entire colon with a colonoscope. So the sigmoid and rectum with the sigmoidoscopy, no full bowel clean out with it needed. Usually no sedation for the sigmoidoscopy or the sigmoid scope rather. Rectal bleeding, diarrhea. Sometimes we'll use just the sigmoid flex sig, what you're called. But that's only getting the lower third of the colon, not the entire colon. So this up to the sigmoid and rectum. But if you have diarrhea and routine colon cancer screening or bleeding, that you're worried about it being more involved throughout the GI system, then from the bottom up, you're going to go with a colonoscope, right? A colonoscopy. Complete view, entire colon. This is what we use for our cancer screening because we're looking at the entire colon. Kind of if you follow it left to right, top to bottom, less invasive, easier, fewer prep, and then less or more limitations on what portion of the colon you're observing. Just the distal rectum and anus on the left of the endoscope, up to the sigmoid colon with the flexible sig, and then colonoscope the entire colon. Just briefly, don't ask me what they're showing, but they're pictures of the bleeding scan. I think the arrows are pointing to where they're showing some bleeding from those arterial structures or venous structures there in the GI tract. But a technetium scan is safe. It's nuclear medicine imaging, right? The one on the left. It's radioactive tracer, analyze what's going on and where you're bleeding. It's used to help locate active GI bleeding. And then the angiogram, arteriogram on the right, minimally invasive. Usually they're going to go in with a catheter. And then they'll go in and they're using x-rays or imaging to look and see if they can identify the source in the GI tract of the abdomen. And then they can, usually there's a dye that's injected there. And you're observing as the positive arrows showing there where you're having those vessels leak out blood. And this is the capsule endoscopy, fancy, new age. What is it? It's a camera in pill form. Swallow it, then they follow it taking pictures or recording all the way through your GI tract. So you wear this little recorder with it for like 8 to 12 hours. 1 to 3 days, it naturally passes, hopefully, goes through digestion and then is excreted out, or goes out with your bowel movement. So a lot of times we'll use these to detect bleeding from Crohn's disease or tumors. You get better imaging, as you can see on the bottom right there. It's kind of occluded, but the capsule endoscopy is another way to see the entire GI tract. It's a recorder of what images it is taken. It's capturing those images, and then you'll go through your system in a day or two. Treatment, large volume bleeding, therapeutic colonoscopy. So we're not testing for cancer with this colonoscopy, right? We're going in to see if we can introduce some treatment to where the bleed is. Either that be cautery or clips or band, or as I mentioned earlier, a vasoconstrictive injection, but something to stop the bleed, using the colonoscope to go up and actually directly close off the bleeding site through one of those methods. Intraarterial embolization, we can do that under an angiograph. As I mentioned, with the angiograph, you can see where it's bleeding, and then we go in through the arteries, go up to where it's bleeding, and then we try to embolize it, stop it from bleeding. Surgery is the last resort. So if you can't get it with a scope, and you can't do it through an angiograph, through a catheter, then we go to surgery. Obscure GI bleeding. So this is defined as GI bleeding that persists after both an upper and a lower endoscopy. So you've gone from top down, you've gone from bottom up, you can't identify it, but the patient's still bleeding, has signs and symptoms of bleeding. Most commonly, that's in the small intestine, and that's when your capsule endoscopy is helpful, right? Because we talked about how far up the colonoscopy looks. We talked about the endoscopy. So small intestine is one, kind of the middle, right? So it's the hardest to reach and see. So a lot of times we'll use that capsule because we know we're going to get the entire GI tract. So if we can identify the bleeding. So occult GI bleeding is not visible to the patient. You need to know that definition. Occult bleeding is not visible to the patient. We're just going to find it on that fecal occult blood testing, or that cancer screen with a colonoscopy, or unexplained anemia. Like, why are we having microcytic iron deficiency anemia in this person? We have to figure out why. Where are they losing blood from? Is it in the GI tract? It's occult, but it's not seen by the patient. And you can lose up to 100 milliliters a day without any real signs. So you can have a pretty significant occult bleed without even knowing that you're bleeding. Stool isn't changing colors. You don't have any of those signs going on with your vitals. And then the test, like I said, we catch it with the DRE, and then we swipe the panel and test it. Oh, there's occult bleed here, right? Our test is positive, or we're doing some other kind of testing, routine cancer screening, and we find the bleed. We can also use the fecal immunochemical test, but that's only for lower GI bleeding. So you're probably going to pick that up with a sigmoid or a colonoscopy anyway. If you have unexplained anemia on the CBC, worry about malignancy. The patient is, especially if the patient is aware, if it's occult. They're not coming in for their GI bleed to find their GI bleed some other way, through a CBC or a routine screening, and now we have to try to identify it, so then we order a follow-up fecal occult or a fecal immunochemical, or we start looking at other causes of occult. If Occult blood is there without anemia, colonoscopy. Without anemia, do a colonoscopy. Why? Because we're worried about an occult bleed could be malignancy, could be a neoplasm. So get your CBC, see what the red blood cells are doing, see what the hemoglobin and hematocrit are doing. And we're basically searching for the source. If you have occult blood with anemia, now we're going in both ends, right? EGD looking down, colonoscopy looking up. If your patient doesn't have anemia, we can go just with the colonoscopy. If there is occult blood, an occult GI bleed, and the anemia comes back on your CBC, then go ahead and get upper and lower. So EGD and a colonoscopy, because you're looking for sources. Capsule endoscopy, we can look at the entire small intestine, so we can look at the entire GI tract. So if we can't get it and identify your patient that has anemia, we think it has an occult bleed, we don't see it with an upper, we don't, and the lower together, then let's do the capsule. So we can try to find, usually it's going to be in the small intestine if you're not seeing it with an EGD or a colonoscopy. So if both those fail, do a capsule. And it's just a picture of everything we just talked about and the different categorizations of upper versus lower, and then is it visible or is it occult? So it's just basically that one little slide is everything we just talked about for like 25 minutes. And that brings us to memory jog, which I won't go through. They're there for you to make your studying, and we will take 10 minutes.
Right in front of the camera.
So
he said that he taught. I thought it was good. I think GE used to be senior class.
Either GI or GU used to be senior class.
Yeah, and you can only how do they demonstrate? 100. So you can get that in the right place. You know, sometimes not always you get an early check-in. Always have it and check out. How is it? What other thing is like membership boards? We get points and use some points.
How are you doing?
What the price fluctuates, just do it and then you can cancel and no harm done. But if the price changes, downtown. My wife and I did it earlier this year. Different hotel. She has a platinum, she's our platinum. So, yeah, it's like a 6 month, it's like years. We get so you got it. I mean, not every city has it. Like I said, yeah, but what's great about this is most of the time it's early because I'm always going to like text all the time. Yeah.
My friend since he felt like eating but maybe she was iron deficient too. I do care, but I'm like, it's okay. I wanted it to move back, like,
yeah, it's not.
it's good and bad right now.
So I always scout and read
yesterday, and they had potatoes and everything. What'd you guys get? And then she was making big old sandwich, chop it up, and it was tender. Yeah. It's really nice. Next morning.
You did March, right?
Dude, just had it. Wasn't eating it, but just like hey, that's good. Everybody's eating it, right? You know? Fredo at 8:30. You watched 10 last night. Like what my doctor said when I got addicted to fettuccine Alfredo. That's a little weird.
Love all of his little lives.
I thought that was one of the most wholesome shows that they had come out with. It just made you feel good after. It made you feel good. No smuttiness. I don't like them disgusting foods. They just needed headlines. Man, I love it. Just make it pretty regular.
I have. I meant when I moved here. When I first moved here.
I was trying to get this on the job. I sell everything on the job. I'm taking all that.
Are you thinking about make a line, holding your hand? Then you won't make it.
Yeah.
Especially if you
Like blocks.
now it's just me and my husband. Lie down here and I have that together. So it's just me and you. That's how I put my cars from 2 weeks ago.
Because they recently changed the milk. I want the whole big gas.
Yeah, that's what I did. Remember? I did the new thing.
Yeah, that's why I was like, well, that's going to be during it. They didn't even have to clean there. It doesn't matter if you're in a month.
I will buy everything. I'll
I'll be here.
driving from Washington.
But the damn thing I was like,
Powder.
do they fix it?
No. I went back and like,
You have trouble with this?
they said, well, unfortunately, you already signed it for your
Outing.
And then they told me, oh, you get all the taxes. Never have.
Anytime that you add, somebody needs to do something.
It's fine.
They get rest like because they come home.
Yeah.
So I don't want to play that fun.
Yes. I did everything the way I was supposed to. And the calculator, so it was
Those are so
$500.
soft. I can just put them all in one.
And
Oh, let's make it. Make it a bunch of separate stuff. Holy shit. We were just one lucky at 2:30.
All right, I'm gonna All right.
Yeah.
Moving on now, we're getting into our first organ, right? So the esophagus. So esophagus, 3 big things that we will, almost every esophagus pathology has 3 things associated with it, or symptoms So dysphagia, what's dysphagia? Difficulty swallowing. What about idonophagia? Odonophagia. Now it's painful. Now it's painful swallowing. And then what is pyrosis? Heartburn. So esophagus, we're going to look at dysphagia, odonophagia, and then pyrosis or heartburn. So difficulty swallowing, now add in difficulty and or pain with swallowing, idonophagia, and then pyrosis, heartburn. Those three complaints pretty much drive us for our diagnosis on the esophagus. Right, so we're going to talk about a few different conditions, mainly GERD, esophagitis, esophageal rings and webs, Zenker diverticulum, and achalasia. That includes esophageal causes for GI bleeds, a little more in depth of what we just talked about with upper GI bleeds, specifically related to the esophagus, which I already gave you a preview about the Mallory-Weiss tears and the Warhead syndrome, and also esophageal cancer. So what is it? It's a tube that connects the food hole to the food bag, right? It just is a muscular tube from your mouth to your stomach. Has a sphincter at the top, an upper esophageal sphincter, and then you have the long muscular tube, and then you have a sphincter at the bottom, the lower esophageal sphincter, where it connects to the stomach. The lower esophageal sphincter, the LES, is what prevents stomach acid from coming up into our esophagus, right? So the LES, or the lower esophageal sphincter, plays a crucial role in gastric reflux. And there's the picture of the anatomy we just discussed. It's about 25 centimeters long, has the upper sphincter of the body, and then a lower sphincter. And as I mentioned, the LES is most important in preventing gastric reflux of gastric contents up into the esophagus. We talked about the signs and symptoms. The three: heartburn or pyrosis, substernal versus epigastric. What do we say epigastric was? Not a disease, but a cluster of symptoms. What do we say epigastric means? With early satiety or fullness after eating. Dyspepsia, remember yesterday? So this is retrosternal. Burning sensation, pyrosis, heartburn, retrosternal. Caused by gastric reflux. Dysphagia, difficulty swallowing. Odonophagia, painful swallowing. And basically we just need to categorize our esophageal issues by which of these symptoms are present and which are not. So dysphagia can be categorized into two types: oropharyngeal, which is difficulty starting to swallow, or you get that feeling that food is stuck in your neck or your throat. So the oropharyngeal dysphagia is often neurologically caused. As it says on the slide, difficulty with the oral or pharyngeal phase of swallowing, and you get a sense of a bolus or pressure or something caught in your neck or in your esophagus. Esophageal dysphagia is as the food is traveling down through the tube, through the muscular tube. So mechanical obstruction is dysphagia to solids only. You need to know that. Mechanical obstruction versus, mechanical obstruction, a motility disorder is mechanical obstruction due to solids. You can, you're having difficulty swallowing solids only. What can cause it? Esophageal cancer, strictures, ribs, and rings. We're going to discuss those in further slides. So when we have motility disorders versus mechanical obstruction to just solids, now we're having dysphagia to both solids and liquids, which is normally achalasia, or it's a classic example. So know those differentiations. between mechanical and motility, and what the dysphagia is associated with. Which one's solids only and which one's solid and liquids. Studies, we've talked about it in almost every lecture for the last 2 days, EGD. Because why? Because it's upper GI tract. So you get there by going top down. So an upper endoscopy, test of choice for esophageal disorders. I would know that. We can also do a barium swallow to identify structural abnormalities or motility disorders. And then we can do a test called esophageal manometry, which will look at muscle function. The barium swallow, as I said, usually for motility disorders, which means they're having dysphagia to what? Solids or liquids? Or both? Both. Then we can, for GERD, we can also do pH monitoring. And that manometry is going to test the function of the lower esophageal sphincter, how that muscle is working on the LES. And then the pH monitoring can be done in GERD evaluation. Okay, GERD specifically. Reflux, acid indigestion. That's what your patient is going to call or complain of about GERD. Basically, gastric contents are getting into the esophagus. Gastroesophageal reflux. Gastric contents refluxing up into the esophagus. Usually, patients have mild disease, but untreated GERD can lead to complications like Barrett's esophagus and even adenocarcinoma cancer. So you start to get structural changes on the lining of the esophagus. Precancerous, being Barrett's esophagus, change in the type of cells from chronic acid exposure. And then once those cells start changing, that's Barrett's esophagus, and then you can actually, further down the road, lead to malignancy. So adenocarcinoma. Usually it's mild, but it can lead to cancer, so treat it. Etiologies for GERD, well, that sphincter that keeps the gastric contents out of our esophagus can stop working, so it's staying open or widened, so acid contents are coming in easier. You can have a hiatal hernia. What's a hiatal hernia? So what organ is going through what organ higher than it's supposed to be? Stomach above diaphragm, right? You can also have conditions that lead to abnormal esophageal clearance. We'll talk about a couple of those. So you can't get food through the tube, so you get GERD. Or delayed gastric emptying, i.e. acid keeps being pumped in, because for some reason your stomach isn't emptying its contents, and we'll talk about those. Or gastric acid hypersecretion. So with the hiatal hernia, you're going to get, as we said, stomach bulging up into the diaphragm, into the chest, and you can get heartburn, or just that classic symptoms we talked about, retrosternal. But we can also get chest pain from it. So rule out any kind of cardiac condition if patients are complaining of GERD symptoms. Also, you can have increased abdominal pressure that's forcing the acid up into the esophagus, like heavy, forceful coughing or heavy lifting. Usually, GERD more common in your older folks, or folks that are obese, or if there's some type of congenital susceptibility issue going on, something in anatomy that's affecting the that LES. So I mentioned it briefly. So the gastric pH is about 4.0 or lower. So your esophagus exposed to that chronically can start having cellular changes on the lining of that musculature, which leads to first Barrett's esophagus, or worst case down the road could be cancer. Basically, esophageal mucosal changes because of caustic exposure to that acid. First, it causes dysplasia. Cells are changing a bit. Then it becomes metaplasia. So now we're going into tumor creation or cancer. Here is a picture of that lower esophageal sphincter. And what we're showing here is the difference between the columnar epithelium of the stomach versus the squamous columnar junction called the Z-line, right there at the LES. So the actual lining of the two different organs are different. But if you start getting acid chronically exposed to that squamous columnar cells that are in the esophagus, they can change, right? There can be dysplasia. Usually there at the Z-line, we're showing that the cellular makeup is different between the esophagus and the stomach until you get chronic exposure. And at that squamous columnar junction, at that transition, you can actually get changes of the cells at the esophagus because of the chronic acid exposure. And here's just another photo of gastroesophageal reflux disease and how we get that GERD symptoms when the LES is not functioning and the acid's moving up above that Z line. Just above the LES. So how's it going to present? Classic. Heartburn, regurgitation, worse after meals, and increased symptoms when you're lying down. Antacids usually help with GERD. I would know those classic symptoms. 30 to 60 minutes after meals. If you lie back or recline, symptoms get worse. I take Tums and it helps. Patients may also complain of water brash, regurgitation of sour fluids. Not vomiting, as we talked about, not actually physically retching and muscle contractions and respiratory contractions making you vomit or throw up, but just regurgitation. It can be sour or it can be almost tasteless. GERD is also a leading cause of a chronic cough, one of the top 3. So when patients are saying they've got a cough and it's cold or flu season, we may want to jump on a URI, but in fact, they could have GERD. You can get hoarseness from chronic GERD, globus sensation, feels like something stuck in your throat. Basically, the globus sensation is common, it can be chronic, you feel like there's a lump or a tightness in the throat, even though if you look down, there's nothing physically still in the esophagus. Don't forget about chest pain. GERD can present as chest pain. Rule out cardiac etiologies as you're hunting down the cause of their GERD. How do they come in? Usually, when you do your exam, you don't see much for GERD, right? It's basically diagnosed based on the symptoms and then ruling out other causes. Sometimes you might have some dental erosions from chronic acid exposure, maybe. Sometimes when we push at the epigastric area, we can get a little tenderness, but not always. Mostly patients just appear normal. Differentials, esophageal motility disorders, i.e. something going on with those muscles that is not functioning to move the food down into the stomach past the LES. A peptic ulcer can be caused by chronic GERD. You start actually getting erosion in the stomach lining. Then we're going to test for what? H. pylori. Right? Angina pectoris, rule out cardiac as a differential. And then also we'll talk a little bit about eosinophilic esophagitis. So some allergy symptoms that can actually causes inflammation of the esophagus. How do we work them up? Usually it's clinical. Benign physical exam, but alarm features, right? We always want to talk alarm features. When do we get worried if someone's saying they have these signs and symptoms? You know, I get this retrosternal pain, 30 minutes, half hour to an hour after I eat. It's worse when I lay down. I take some Tums or I take an antacid, it helps. All right, we're thinking GERD, but when do we get more nervous, right? Dysphagia, difficulty swallowing, or odynophagia, if they have pain with swallowing. Unintentional weight loss, persistent vomiting, iron deficiency anemia. So our alarm symptoms are pretty much the same as they are for any disorder in the GI tract. And what do they get? What do you think? What kind of testing? It's up here, EGD. Up top looking down. It's the upper GI tract. EGD is only if you have alarm symptoms. And that's your list there. And as I mentioned just before this, if you're having that unexplained iron deficiency anemia, we're going from the bottom and the top. Figure out where you have your cold GI bleed. Usually no testing. Clinical diagnosis unless one of these present. And like almost everything other than dyspepsia and EGD that we mentioned, if you're over 50 and it's a new onset, get the EGD. So if the patient continues to have symptoms, even if you put them on an acid treatment, right, you could start with H2 blockers. PPI is kind of the drug of choice, but I think the next slide we start getting to the treatment. But if they continue to have symptoms, then go with that EGD. Test of choice, EGD. You can look at the esophagus, stomach, and the upper part of the small intestine. Specialists will get the manometry or the esophageal pH. If you're referring to GI, they'll do that. Normally, you're not going to be doing that in your primary care clinic, but possibly. But normally, specialists involved, and we want to start doing anything above an EGD. You're not going to do an EGD in your office either, but you can send them out for an EGD. But when you start talking about pH measuring and that muscle testing for manometry of the LES, then you become a GI specialist. Call a friend. So there is a classification for GERD, and basically we're looking at the endoscopic appearance of the esophagitis, of reflux esophagitis. We talked about those changes. I don't expect you to know these, just know it exists in the world. The Los Angeles classifications, I'm not going to test you about the different phases and what the actual cells on the esophagus look like based on this classification system. Treatment. Everybody gets lifestyle changes. Everybody gets lifestyle changes. Smaller meals. Don't eat so much. Don't eat such spicy foods. Don't lay down after you eat if laying down makes it worse. Common sense, right? Unexplained, weight loss. Encourage weight loss. That will help with GERD, or that reflux. Because why? There's less pressure in the abdomen, right? There's less mass there. Stop smoking if you have GERD. And if you don't have GERD, but especially if you have GERD. Because nicotine relaxes the LES. And if you know what makes it worse, every time I have chocolate, I get reflux or I get GERD. Sorry to say, you should probably shut out chocolate. So if something makes it bad, the patient can tell you, then you say, well, don't do that. Won't work, let's have chocolate. That's okay. You tell them don't do it. Or alcohol, then stop drinking. No, give me medicine. But try to lifestyle as much as you can. Keep patient in here. Lifestyle modifications. Avoid laying down for 3 hours, so eat your meals earlier. Don't eat or drink right before you go to bed, because what does that cause? That causes the stomach to start producing acid. So if you're eating or drinking right before you go to bed, and you get GERD after you eat or drink, well, you just brought that symptom while you're trying to go to sleep, because now you've activated acid production from your stomach as the food or beverage moves through your GI tract. Use pillows to elevate your head. It's simple physics, right? If it's coming up and it's worse when I lay down, it comes up, then we'll sit up, and that'll keep it from coming up. Gravity. Lose weight will help. Now, they won't do any of the lifestyle stuff, or it hasn't helped, so less treatment, right? Over-the-counter antacids, a lot of patients in mild GERD will get some relief, usually pretty quickly. Doesn't last forever, but it's usually pretty quick onset that an antacid will kind of break that pain cycle and decrease the acid, so they feel better. We can give them H2 blockers for moderate symptoms. So Tagamet, Pepcid, Zantac. Last longer, last about 8 hours. On the antacids, I failed to mention, be careful with antacids in your patients with chronic kidney disease. It's on the slide, I pointed out. Most effective for GERD, PPI, good old PPI. For the H2 receptor for the Tagamet and Pepcid, you can actually give them and tell them to take it before their meal. So you're getting out in front of what's about to come from activating the stomach enzymes and the acid production. PPIs for moderate GERD, first line therapy, drug of choice. Moderate GERD equals first line therapy PPI. Boards are going to ask you that. Or GERD, moderate, PPI first line. Usually it's taken in the morning, 30 minutes before breakfast, and we don't give them our PPI and say, here you go, take it forever. That's what happens a lot of times. And people are on PPIs for like in depth, right? But normally we want to do a trial of 8 weeks. Trial of 8 weeks is the board question. 30 minutes before breakfast, they work better than H2 blockers. We mentioned lifestyle modification. I think it's important because it's on 3 slides. So if they're having those moderate symptoms, like greater than twice a week, we're going to do a daily PPI 30 minutes before breakfast for about 8 weeks. Starting low, and you can step up the PPI. If it mildly helps, okay, we can up the dose a little bit. If after 8 weeks they come back in and it hasn't helped, what do you do? It's on the slide. EGD. Correct. Like most upper GI issues, if our first line doesn't work, second line doesn't work, or alarm symptoms, then send them out for the Talk to your patients about complications, right? Because this will motivate them to follow your instructions, or at least attempt to follow your instructions on lifestyle modifications and improve medication adherence when you say this GERD can actually lead to cancer. The lining changes. It starts to look like intestinal tissue. And you also get like a salmon color to it versus white as it starts to go through the dysplasia changes. And what does that mean? Often asymptomatic, but you're heading down towards cancer bill, right? You're getting those changes, you're getting dysplasia. Make sure you discuss it with your patients. Alarm symptoms, EGD, we mentioned it. After 12 weeks, if they're having symptomatic relief, they're not having any issues, yes, you can give them a drug holiday. But if it comes back, do an EGD, and if they don't have any conditions that need to be treated otherwise, you put them back on it, because most of the patients are going to relapse and require therapy continuously with PPIs. So if it controls their symptoms, lowest dose as possible. But it's okay to be on it as long as you've done the follow-ups and done the referrals and gotten the testing and said there's nothing else going on here, that you can keep them on PPI. And then encourage those lifestyle modifications. Refractive and medical treatment, there is a surgical option. Listed there on the slide, Nissen fundoplication. Basically, take the stomach, pull it up on the esophagus, wrap it around it, sew it together. So the stomach around the esophagus. I think that picture can know. So fundus of the stomach wrapped around the esophagus, sewn into place. So basically, the bottom of the esophagus is going through a little stomach pouch that you create. So what's that doing? It's moving the esophagus down further and not exposing it to the gastric contents of the upper stomach because you've moved it up higher. Acts as a reinforcement for the LES. And here's a picture of it. Just know the name of the surgery, and there's a surgical option for folks that don't respond to chronic refractory. Major complications of GERD, Barrett's esophagus. Normal squamous epithelium is replaced by columnar epithelium. If you got Barrett's, now your risk of cancer going way up. And here's just a picture. I described it earlier. We showed you a picture too, but basically you can see the changes that are occurring on the normal esophageal mucosa. GERD complications, peptic stricture. So basically what is it? Scarring and narrowing of the esophagus. Right? Chronic exposure to acid, starts to get scarring there. Well, your food tube just got smaller due to inflammation. What happens is they start to develop progressively worsening solid food dysphagia. How do we treat it? We put an endoscope down and we stretch it out. Endoscopic dilation. So it gets narrowed, not we, but we send it out to a specialist who then goes in and stretches out the LES. Endoscopic dilation for peptic strictures. Treatment. Definitive treatment, I would know that. And the signs are that progressive solid food dysphagia with chronic GERD. Question. All right, moving into inflammation, strictures, and motility disorders. So esophagitis, inflammation of the esophagus. 3 important types: infectious, pill-induced, or eosinophilic esophagitis. Infectious can include candida, CMV, or herpes virus. We'll talk about what pills and what the eosinophilic esophagitis is in the upcoming slides. So infectious esophagitis, inflammation, right? Irritation, inflammation of the esophagus, just like it sounds. Or you can get some swelling. Can be with a fungus, a yeast, or a virus. Mostly this happens in your immunocompromised patients where they get infectious esophagitis. AIDS patients, organ transplant patients, leukemia, lymphoma, chronic immunosuppressive. So usually if you have a decreased immune system, then that's when you're going to be exposed to higher risk of infectious esophagitis. With infectious esophagitis, just remember dysphagia and adynophagia. So painful swallowing and difficulty swallowing. Much like any issue with the esophagus. So basically you figure out what's causing it. They've got that dysphagia, adynophagia, may have some chest pain or tenderness to palpation at the epigastric area. But basically diagnosis and specific etiology is determined with an EGD with biopsy. So you go into the area and do the upper endoscope, you see where the inflammation is, where the swelling is, inflammation is, you take a little piece of it, lab looks at it under a microscope and says, okay, what I'm seeing here is consistent with one of those infectious causes, right? CMV, herpes. So you're determining, diagnosing what the issue is with the EGD, and then once you know what it is by examination from the tissue, then you treat it based on what is it, candida, is it CMV, or is it herpes, three examples that we gave you. So you treat based on what etiology is there. And there's just picture of the three. You don't need to know the appearance. All right, pill-induced. There's your big players. NSAIDs, just like you have to protect the stomach, the GI tract. Esophagus is part of the GI tract, so NSAIDs cause inflammation in the esophagus. Potassium chloride pills, and there's your whole list. I don't expect you to know the entire list. What I would say is doxycycline is a big cause, and NSAIDs are a big cause, and bisphosphonates for osteoporosis, like we talked about, or we tested on Monday. So those are three big players I would want you to know. NSAIDs, doxy, and bisphosphonates, and the fourth one would be potassium pills. So common things that our patients would be on, that if they're starting to have signs and symptoms of esophagitis, medication-induced, pill-induced, think about those antibiotics. It's the macrolides and doxy, and then the NSAIDs, potassium, bisphosphonates, and vitamin C. You don't need to know the entire list. Eosinophilic esophagitis, immune-mediated inflammatory response. Allergies, right? It's eosinophilic associated, so is allergies. Could be food, could be environmental. Basically, you get an eosinophilic infiltration of the esophageal mucosa. That inflammation leads to progressive difficulty swallowing, known as dysphagia. And you can actually get narrowing of the lumen, like we discussed with the other causes of other etiologies of esophagitis. So since it's allergic associated, think about it in patients that start having dysphagia that have a history of asthma, severe allergies or seasonal allergies, if they have any history of atopy or atopic dermatitis. So if you get progressing dysphagia to solid foods, as your food tube's closing down because of the chronic inflammation, start thinking eosinophilic if they have those allergic diseases in their history. Once again, ask about history of asthma, allergies, and atopic dermatitis, i.e. eczema. Usually this is worsening dysphagia to solid foods. That's the most common complaint because your food tube is inflamed. So you can't get it down. Heartburn is another clinical finding. What do? Yes, EGD. And you take a biopsy of it, and they look at it, and they say, look, eosinophilic infiltrates of the esophagus. How do we treat it? Empirically with a PPI. It's like much of these disorders. You can give your patient a topically swallowed corticosteroid. There are topical corticosteroids that act on the GI tract. And you can send them out to an allergist to figure out what they're allergic to. See if we can get that. Either they can get like some immunoglobulin therapy to decrease their sensitization, or put them on some type of antihistamine. And it lists on your slide the topical corticosteroid, fluticasone, from the inhaler, right? Just like you use it for asthma. You take it in this case to decrease the allergic response and the eosinophilic response to allergies in the esophagus. Refer to an allergist before you start giving the topical corticosteroid. Esophageal webs and rings. So basically the webs are thin membranes in the upper esophagus, and then the Schatzky rings are in the distal esophagus. Both can lead to intermittent solid food dysphagia. So it comes and goes. The webs are thin membranes of the squamous epithelium in the mid to upper esophagus, and those webs, and you can see the picture there, most of them asymptomatic. But you can get the intermittent dysphagia or GERD-like symptoms. It comes and goes, it waxes and wanes from esophageal webs. Then know that the Schatzky rings are just lower in the distal esophagus. And here's our entire slide dedicated to it. So it's circumferential mucosal structure, distal esophagus, similar to the webs, intermittent dysphagia. But know the association of esophageal ring, i.e. Schatzky rings, with hiatal hernias. Know that there's an associated, strong association. Hiatal hernia and esophageal ring, specifically the Schatzky rings in the lower esophagus. Here's just a barium swallow test showing you those strictures. How do we treat it? Just like when you start having narrowing of the LES earlier, now we talk about endoscopic dilation to open it up if they're having concerning intermittent dysphagia. But a barium swallow is the diagnostic test, which is a picture of what you're looking at there. An evaluation after the patient swallows barium dye, showing how the barium or liquids are moving through the esophagus. Zenker diverticulum. This one's interesting. It's a pharyngeal esophageal pouch. Up on the backside of the esophagus is just a little out pouch. You get dysphagia and halitosis. The halitosis is because food and fluids get trapped in the little pouch. So then it sits there, and obviously you're going to get bad breath with partially digested food or undigested food and liquids sitting in a pouch in your upper esophagus. You also can regurgitate some of that undigested food because it's basically hung up in a little pouch in your esophagus, and there's a picture of it coming up. So you get a feeling of food stuck in your throat because there's food stuck in your throat. It's just not directly in the esophagus. It's in the Zenker diverticulum pouch, the pharyngeoesophageal pouch. You can also regurgitate it, as I mentioned. How do we diagnose it? Barium swallow, just like the rings, Schatzky rings, or the webs. And remember, this one is associated with that sensation of stuck food because it is progressive difficulty swallowing and bad breath because you have food undigested stuck in a little pouch. So we do a barium swallow and then we see it, which you can see the barium swallow on the right, and it's just a little fanny pack hanging out in the esophagus, right? Collecting things. Zenker diverticulum. Moving on to achalasia, motility disorder. Why? The LES relaxation is impaired. Motility, so it affects dysphagia to what? Solids or liquids or both? Both. It's a motility disorder, achalasia, so dysphagia to solids and liquids. It's idiopathic esophageal motility disorder. Basically, the lower 2/3 of the esophagus isn't performing normal peristalsis. It's not moving things out of the tube into the stomach. Impaired relaxation of the LES. So progressive dysphagia to solids and liquids because it's motility. Once again, regurgitation of undigested food. Why? Because it's not in a pouch, but it just can't get through the LES because it's narrowed there. So same kind of signs and symptoms, just from two different underlying causes. You get some substernal discomfort after you eat. Why? Because the food isn't moving through the LES into the stomach like it's supposed to, because of that narrowing of the two a patient will say, hey, I do these maneuvers to enhance emptying. They're massaging, they're holding their breath, jumping up and down, just trying to get the food to move out of their throat because they have that sensation of food stuck in their throat, because it is. It's not moving. And it's both solids and liquids. And you can get weight loss. Why? Because you're not digesting everything you're putting in. Physical exam usually unremarkable. Classic, every board you'll ever see is going to ask you about the bird beak's deformity on a barium swallow. And it is achalasia. There is no other thing associated with it. Bird beak deformity, and I got a picture of barium swallow, that's your achalasia. Physical exam, otherwise unremarkable. They just have reporting those signs and symptoms we just spoke about, specifically progressive dysphagia to both solids and liquids. You're going to send these folks out to confirm after the barium swallow with the GI specialist, because they're going to get some manometry, testing the muscle of the LES. Because basically, in this case, the LES isn't relaxing like it's supposed to. It's doing a good job of keeping the acid out, but it's not doing a good job of letting food and liquids get through the tube to the stomach to be digested. Bird's beak deformity, tapering, distal portion of the esophagus, EGD, barium swallow, and then send out for manometry. And there's your picture of the bird's beak. Narrowing of that distal esophagus. LES is cinched down. Differentials, Chagas disease, which is a parasitic disease caused by the Trypanosoma cruzi. I'm sure you had it in ID. I'm not going to ask you about it, but it's in your differential. What it does, you get esophageal dysfunction with that infection, and it mimics those signs of achalasia, but it's more sudden onset. So how do we treat achalasia? If we do our EEG, we do our barium swallow, we send them out for manometry, it is achalasia. So dilation, right? Pneumatic dilation. Recently, they've started to treat it with botulism toxin injections. So relaxing that muscle sphincter with botulism toxin, or surgical correction, surgical myotomy. Obviously, those are all going to be done by a specialist. Refer to GI surgery, as I mentioned, specialist. Inject it with botulism, dilate it under air, pressure, or cut it out. Open it. All right, we have probably like 10 slides more. We can pick back up on tomorrow's against spot to stop because we're moving back into GI. So